Hello and welcome to Dr. Wala Adin Ahmed's revision series. Today, we are diving into a topic that is both highly prevalent and frequently examined: migraine and headache in adults. So grab your notes and let's get started. This video is intended strictly for educational and academic purposes only. The content presented here is based on current medical literature and guidelines and is designed to support students and healthcare professionals in their learning journey. Nothing in this video constitutes medical advice, a clinical recommendation, or a substitute for professional medical consultation, diagnosis, or treatment. Always refer to qualified healthcare professionals and current clinical guidelines before making any medical decisions. Medications and dosages mentioned are discussed in an educational context only and must not be applied to individual patient care without proper clinical assessment. So, what exactly is migraine? Migraine is defined as a chronic, episodic neurological disorder with a strong genetic component. It typically presents in early to midlife and is characterized by recurrent headaches that are often accompanied by nausea, photophobia, that is sensitivity to light, phonophobia, which is sensitivity to sound, and a significantly reduced ability to function. Now, an important clinical pearl here: in approximately 15 to 30% of patients, a migraine aura precedes or occurs alongside the headache. This aura is a complex of reversible neurological symptoms, visual, sensory, or speech-related, and we will explore this in detail in just a moment. In terms of impact, migraine significantly affects quality of life, and crucially for your exams and clinical practice, it is frequently underdiagnosed and undertreated. Keep that in mind. Now let's look at the numbers, because the epidemiology of migraine is striking and examiners love it. Globally, migraine affects a staggering 1.16 billion people. In the United States alone, the total prevalence is 15.9%. But when you break that down by sex, the disparity becomes very clear: 21% in women versus 10.7% in men. So, migraine is roughly twice as common in women, and we will come back to that when we discuss risk factors. And for chronic migraine specifically, defined as 15 or more headache days per month for more than 3 months, the prevalence sits at approximately 0.91%. These numbers tell us that we are dealing with a massive public health burden, not a niche diagnosis. Now, let's move on to the pathophysiology of migraine. Let's walk through the key mechanisms. The first concept is brain hyperexcitability. The migraine brain has a deficient regulation of the cortical excitatory-inhibitory balance. In simple terms, genetic factors increase neuronal excitability, making the brain hypersensitive to a wide range of internal and external stimuli. Think of it like a smoke detector that is set far too sensitive. It triggers at the slightest provocation. The second mechanism is trigeminal system activation. This is central to migraine pain. Neurogenic inflammation of the trigeminal sensory neurons drives changes in pain processing. When these neurons are activated, they release key neuropeptides: CGRP, which stands for calcitonin gene-related peptide, substance P, and bradykinin. The release of these molecules causes blood vessel dilation and peripheral sensitization. This is why CGRP has become such an important therapeutic target, and we will revisit this in treatment. The third mechanism, and perhaps the most well-known, is cortical spreading depression. This is a slowly propagating wave of neuronal excitation that spreads across the cortex at a rate of 3 to 5 millimeters per minute, followed by a phase of suppressed neuronal activity. This wave releases inflammatory mediators that activate the trigeminal pain pathways, and this is the phenomenon that underlies the migraine aura. So, in summary, genetic hyperexcitability leads to cortical spreading depression, which triggers the trigeminal system, which produces the pain and associated symptoms we call migraine. Beautiful in its mechanism, but absolutely debilitating for the patient. Now let's talk classification. Migraine is formally classified by the International Headache Society under the ICHD-3, the International Classification of Headache Disorders, 3rd edition. The three main categories are, number 1, migraine without aura. This is the most common form. Attacks last between 4 and 72 hours and are characterized by unilateral, pulsating pain of moderate to severe intensity. Number 2, migraine with aura. Here, reversible visual, sensory, or central nervous system symptoms precede or accompany the headache. This category has important subtypes. Firstly, typical aura, which can occur with or without headache. Secondly, migraine with brainstem aura, think dizziness, diplopia, dysarthria. Thirdly, hemiplegic migraine with motor weakness. Lastly, retinal migraine with monocular visual disturbance. Number 3, chronic migraine, defined as headache occurring on 15 or more days per month for more than 3 months. Learn these categories. They help structure your clinical thinking. Moving on to complications, these are high yield and can present as serious clinical scenarios. First is status migrainosus, a debilitating migraine attack lasting more than 72 hours. This is a medical emergency scenario requiring urgent management. Second is persistent aura without infarction, aura symptoms persisting for 1 week in the absence of any brain damage on imaging. Third, and this is a critical one, migrainous infarction. This is a stroke that occurs during a typical migraine with aura episode. Patients with migraine with aura have an increased cerebral vascular risk. Remember this. Fourth is migraine aura-triggered seizure, a seizure triggered by a migraine aura event. Next, we have 2 categories of probable migraine. First, we have probable migraine without aura, cases that almost meet the full ICHD-3 criteria but are missing one diagnostic element, and migraine with aura but not meeting all other criteria of migraine. It is important to know that there is what we call migraine-associated episodic syndromes, which include recurrent gastrointestinal disturbance, such as cyclical vomiting syndrome and abdominal migraine, benign paroxysmal vertigo, and benign paroxysmal torticollis. These are especially relevant in pediatric and young adult populations. How do we diagnose migraine? The answer is primarily through a thorough history and clinical examination. There is no blood test or scan that diagnoses migraine. The diagnosis is clinical. Let's go through the key diagnostic factors. The first is recurrent headaches that interfere with daily functioning. This is the cornerstone. Second, the pain characteristics, pulsating or throbbing in quality, moderate to severe in intensity, often unilateral, though it can be bilateral, and importantly, worsened by routine physical activity, such as walking upstairs. Third, associated symptoms, nausea and/or vomiting, photophobia and phonophobia. Remember, you need at least 2 of these associated features. Fourth, duration. Untreated attacks last between 4 and 72 hours. If a headache resolves in under 4 hours or lasts beyond 72 hours without intervention, question your diagnosis. Fifth, aura, reported by approximately 1/3 of patients, includes positive phenomena like sparkling lights or geometric shapes, and negative phenomena like visual loss, numbness, or speech disturbance. A very useful practical tool is the headache diary or calendar. Encourage patients to track the frequency, duration, severity, and triggers of their headaches. This is invaluable for both diagnosis and monitoring treatment response. And remember, one patient can carry multiple headache diagnoses simultaneously. Always assess comprehensively. Now let's consider what increases someone's risk of developing migraine. Starting with strong risk factors. Family history is the most significant. Migraine has a strong genetic component, with autosomal dominant forms identified, particularly in familial hemiplegic migraine. If a first-degree relative has migraine, the patient's risk is substantially elevated. Obesity, a BMI over 30, is associated with increased prevalence and increased frequency of attacks. This is both a risk factor and a target for intervention. Female sex. Migraine is 3 times more prevalent in women, particularly during the reproductive years. This is linked to hormonal fluctuations, especially estrogen, which explains menstrual migraine and the impact of pregnancy and menopause. Medication overuse. Overusing acute medications, particularly analgesics, can paradoxically lead to medication overuse headache and push patients into chronic migraine territory. This is critically important in management. Now let's discuss weak but important risk factors. Low socioeconomic status, allergies or asthma, sleep disorders, including insomnia and sleep apnea, stressful life events, and hypothyroidism have all been associated with migraine prevalence in epidemiological studies. Here is a key principle to internalize. We do not investigate to diagnose migraine. We investigate to rule out dangerous secondary causes. If a patient has a normal neurological examination and a history that fits classical migraine, no investigations are routinely required. So when do we investigate? When red flag features are present. The slides highlight the most important warning signs. A sudden onset thunderclap headache, worst headache of your life, reaching maximum intensity in under 60 seconds. Think subarachnoid hemorrhage until proven otherwise. A progressively worsening headache over weeks to months. Think space-occupying lesion. A headache associated with fever, neck stiffness, or altered consciousness. Think meningitis or encephalitis. New neurological signs or symptoms. Papilledema on fundoscopic examination. Headache following head trauma. Now, what tests do we use? MRI brain, the preferred imaging modality for concerning headaches, rules out space-occupying lesions. CT head for emergency evaluation, particularly when assessing for acute intracranial hemorrhage. Blood tests, ESR and CRP to investigate for inflammation, vasculitis, or giant cell arteritis, especially in patients over 50 years old. Lumbar puncture, indicated when subarachnoid hemorrhage is suspected, and the CT scan is negative. Remember, CT picks up SAH in about 95% of cases within the first 6 hours, but LP may still be needed. All of these tests will be normal in a straightforward migraine. Differentiation is a classic exam question, so let's nail it. Migraine versus tension-type headache. Migraine is typically unilateral, throbbing, and accompanied by nausea, photophobia, and phonophobia. It is worsened by physical activity. Tension-type headache, by contrast, is bilateral, described as a pressure or tightening sensation, like a band around the head, and is not worsened by physical activity. Migraine versus cluster headache. Cluster headache presents as severe, piercing eye pain, strictly unilateral, often periorbital or temporal. It is associated with autonomic symptoms on the same side, lacrimation, conjunctival injection, nasal congestion, ptosis. Patients are typically restless, even agitated during the attack. Key demographic difference: cluster headache has a strong male predominance, while migraine is more prevalent in females. Cluster attacks are also shorter, typically 15 to 3 hours, compared to migraines 4 to 72 hours. Serious causes to always rule out. When you see thunderclap onset, new neurological signs, fever, or papilledema, consider subarachnoid hemorrhage, meningitis, or a brain tumor. Do not miss these. Now, 2 excellent screening tools are worth knowing, particularly for primary care settings. The first is the 3-item ID migraine screen. This is a validated quick tool for primary care patients reporting headache in the last 3 months. It asks just 3 questions. 1. Has a headache limited your activities for a day or more in the last 3 months? 2. Do you feel nauseous or sick when you have a headache? 3. Does light bother you when you have a headache? The clinical impact. If a patient answers yes to 2 out of 3 of these questions, there is approximately 93 out of 100 chance they have migraine. That's a highly sensitive tool. The second is the Migraine Screen Questionnaire, a slightly more detailed 5-question alternative for more comprehensive assessment in clinical settings. These tools are quick, practical, and help avoid underdiagnosis. Now we move into management, which is where the exam marks really stack up. Let's start with the overarching principles. The main goal of migraine management is to find a reliable, rapidly effective treatment for acute attacks that restores the patient's ability to function. Treatment must always be individualized based on severity, patient characteristics, comorbidities, and patient preferences. Management falls into 2 broad pillars. Acute treatment, treating the attack as it happens. Start early, ideally when symptoms are still mild. Consider treating during the prodrome phase if identifiable. Include antiemetics to manage nausea and vomiting. Ensure adequate hydration throughout. Preventative treatment, reducing attack frequency and severity, indicated for frequent attacks, when acute treatments are ineffective or not tolerated, to prevent medication overuse and the drift into chronic migraine. Individualized planning. In older adults, carefully consider comorbidities and drug interactions. In pregnant women, therapy selection requires extra caution, and we will dedicate an entire slide to this. Monitor treatment response using headache diaries and the MIDAS, the Migraine Disability Assessment Score. This quantifies how much disability migraine is causing and guides treatment escalation decisions. Let's now work through the acute treatment ladder, starting with mild symptoms. First line, NSAIDs. These are your go-to options for mild to moderate migraine. The key doses to remember are aspirin 900 to 1000 milligrams, diclofenac potassium 50 milligrams, ibuprofen 400 to 600 milligrams, naproxen 500 to 750 milligrams. The golden rule here is NSAIDs are most effective when used early in the attack. The earlier you treat, the better the outcome. This is true across all migraine therapies, but especially relevant for simple analgesics. Second line, paracetamol. Paracetamol 1000 milligrams, oral or rectal, is indicated when NSAIDs are contraindicated, for example in renal impairment, peptic ulcer disease, or aspirin-sensitive asthma. Third line, combination therapy. Combinations of paracetamol, aspirin, and caffeine are more effective than any single agent alone. The caffeine enhances absorption and analgesic efficacy. Don't forget the adjuncts. Antiemetics such as metoclopramide or prochlorperazine address nausea and also improve gastric motility, which enhances oral drug absorption. Hydration, oral or intravenous, should not be overlooked. When symptoms are moderate to severe, we escalate. First line, triptans, the 5-HT1 receptor agonists. Triptans are the cornerstone of moderate to severe migraine treatment. They work by selectively activating serotonin receptors in the trigeminal system, reducing neurogenic inflammation and causing vasoconstriction of dilated cranial blood vessels. Primary options include almotriptan, electrotriptan, rizatriptan, sumatriptan, which can be given orally, subcutaneously, intranasally, or as a transdermal patch, and zolmitriptan. Secondary triptans with slower onset but longer duration include frovatriptan and naratriptan, useful for longer attacks or menstrual migraine prophylaxis. Key point: if one triptan is ineffective, try another. Response to individual triptans varies between patients. Do not write off the entire class. Important contraindications for triptans are cardiovascular disease, uncontrolled hypertension, and history of stroke. Do not use in patients with brainstem or hemiplegic migraine. Second line, CGRP antagonists, the gepants. These are newer agents, Rimagent, Ubrogent, and Zavagent. They block the CGRP receptor, remember our pathophysiology, and are used when triptans are ineffective or contraindicated. Crucially, they are safe for patients with cardiovascular disease. Some gepants also have a role in preventative treatment. Adjunctive options remain the same: antiemetics, hydration, NSAIDs or paracetamol, and non-invasive neuromodulation devices. When outpatient treatment has failed and the patient presents to the emergency department, here is how we manage. Emergency department approach. Intravenous antiemetic, metoclopramide or prochlorperazine, often given with diphenhydramine to reduce the risk of dystonic reactions. Promethazine as an alternative antiemetic option. Subcutaneous sumatriptan, this is the American Headache Society's preferred triptan route in the emergency setting due to rapid onset. IV ketorolac, valproic acid, haloperidol, or paracetamol as additional options. Supportive care. IV fluids for prolonged attacks with significant nausea and vomiting. High-flow oxygen may provide relief in some patients. IV dexamethasone. Evidence supports its use to prevent headache recurrence after emergency treatment. IV magnesium, consider especially in patients with aura, as evidence supports its efficacy in this subgroup. And now, a critical point that must be emphasized. Avoid opioids. I will say that again. Avoid opioids in migraine management. They carry a significant risk of dependence, misuse, and overdose. They are less effective than targeted migraine therapies, and they are associated with worsening headache chronification and medication overuse headache. Unless there is an exceptional clinical circumstance, opioids have no place in migraine treatment. Pregnancy requires a special discussion because medication choice becomes significantly more complex, and the consequences of getting it wrong affect both mother and baby. Preconception counseling is essential for any woman of reproductive age who has migraine. Plan ahead. Safe options in pregnancy. First choice, paracetamol. This remains the safest analgesic throughout pregnancy. For nausea, metoclopramide combined with diphenhydramine. Second trimester only. NSAIDs may be used for intractable cases, but they are contraindicated in the first and third trimesters due to risks of miscarriage and premature closure of the ductus arteriosus, respectively. Sumatriptan, with caution and only in women without cardiac disease. Limited data, but current evidence is reasonably reassuring. IV magnesium, acceptable for short-term use. Oral prednisone for severe refractory cases when other options have failed. Contraindicated in pregnancy, CGRP antagonists, gepants, and CGRP monoclonal antibodies, insufficient safety data. Ergot derivatives, potent uterotonics, strongly contraindicated. Aspirin at analgesic doses, risk of hemorrhage and fetal effects. Opioids, risk of neonatal abstinence syndrome. Valproic acid, highly teratogenic, absolutely contraindicated. The guiding principle throughout pregnancy is use the safest medication at the lowest effective dose for the shortest possible duration. Our final topic today is preventative or prophylactic migraine treatment. This is an area of growing importance, particularly with newer biologics changing the landscape. When do we consider prevention? When migraine attacks significantly interfere with daily activities despite adequate acute treatment. When attacks are frequent, generally 4 or more headache days per month is the threshold most guidelines use. When there are contraindications to acute treatments or the acute treatment are causing significant adverse effects. When treatment failure or overuse of medications. The key components of a preventative strategy are 1. Trigger identification and avoidance. Common triggers include stress, sleep disruption, dehydration, skipping meals, hormonal changes, and certain foods or alcohol. Identifying and managing these is the first step. 2. Non-pharmacological therapies and lifestyle modifications. Regular sleep schedule, regular meals, adequate hydration, aerobic exercise, stress management techniques, and cognitive behavioral therapy all have evidence behind them. 3. Individualized pharmacological treatment selection. Preventative agents include beta blockers, propranolol and metoprolol, antidepressants, amitriptyline, anticonvulsants, topiramate and valproate, CGRP monoclonal antibodies, erinumab, fremenizumab, galcanezumab, eptinezumab, the newest class, highly effective, particularly for chronic migraine. Gepants, such as Rimagent, also have a preventative role, and onabotulinum toxin agent injected every 12 weeks for chronic migraine specifically. The key message is preventative treatment choice must be individualized. Consider patient preferences, medical history, comorbidities, potential drug interactions, and the overall impact on quality of life. 4. Regular monitoring and treatment adjustment using headache diaries and the MIDAS questionnaire, the Migraine Disability Assessment Score. This quantifies how much disability migraine is causing and guides treatment escalation decisions. And that brings us to the end of today's session on migraine and headache in adults. Let's quickly recap what we've covered. Migraine is a common, chronic neurological disorder driven by brain hyperexcitability and trigeminal activation. It's classified under ICHD-3, and knowing the subtypes is essential. Diagnosis is clinical. Investigate only to exclude dangerous secondary causes when red flags are present. Differentiate carefully from tension type and cluster headaches, and always rule out serious pathology. Acute treatment follows a stepwise approach. NSAIDs and paracetamol for mild attacks, triptans and Gepants for moderate to severe. Avoid opioids. In pregnancy, treatment options are narrowed, but paracetamol remains safe first line. Preventative treatment is indicated for frequent or disabling attacks, with newer CGRP-targeted therapies transforming care. I hope this session has been helpful and that you feel confident tackling migraine questions in your exams and in clinical practice. This has been Dr. Ahmed's Revision Series. Thank you so much for watching, and I will see you in the next session.